Welcome back to the deep dive.
It's great to be here.
Today we are, well, we're not just skimming the surface of some minor medical update. We are really getting into a document that I think fundamentally changes the landscape for a lot of us.
Oh, absolutely. This is a big one.
I mean, for allergists, for dermatologists, and really, any clinician who's ever looked at a patient just covered in hives and had that moment of,
Well, now.
exactly, what now? We are tackling the 2026 International Guideline for the Definition, Classification, Diagnosis, and Management of Urticaria.
And to call this just a guideline almost feels like, well, like an undersell. This is the consensus.
It really is.
We're talking about the combined brain power of GALEN, that's the Global Allergy and Asthma Excellence Network, along with UCARE and ACARE. This isn't just a few experts in a room.
No, the scale is massive.
It's 213 delegates from 59 different countries.
That's just staggering. I mean, getting 213 people to agree on where to go for lunch is hard enough.
Right.
Getting them to agree on a clinical algorithm?
Yeah.
That takes some serious methodology.
It does.
Yeah.
That's actually, I think, a really important place to start. The weight of this document comes from how it was built.
Okay, so let's talk about that.
They used the GRADE methodology. That's the grading of recommendations, assessment, development, and evaluation. And they finalized all of this at a consensus conference in Berlin back in December of 2024.
And they use something called the nominal group technique.
Yes.
So break that down for us. Why does that matter to, the clinician listening to this while driving to their clinic right now?
Because it stops the loudest voice in the room from dominating the conversation.
Yeah.
It's a structured voting system. Everyone gets their say, and then they vote.
I see, so it's more democratic.
Exactly. And to get a recommendation labeled as a strong consensus, they needed over 95% agreement from the delegates who were voting.
95%.
And what's just so striking when you read this 2026 update is how many recommendations actually hit that threshold. It's incredible. We have this remarkably unified global front on how to manage urticaria now.
So our mission today is to take this massive PDF, which is basically the blueprint for clinical practice for the next 4 years, and operationalize it for you.
Right. How do you use this on Monday morning?
Exactly. We're going to look at the new boundaries of the definition, the less is more diagnostic philosophy, which I think will surprise a few people, and of course the 2026 treatment algorithm.
And that's where some of the biggest changes are. Some very significant new players in the biological space.
Including some oral options that might finally bridge that gap between just antihistamines and, going straight to injectables.
That's right. It's a big shift.
Okay. But let's start the foundation. Section 1, definition and classification. The guideline spends a lot of real estate, a lot of pages, defining what urticaria is, but it seems almost equally obsessed with defining what it is not.
It is, and for very good reason.
Yeah.
Because hives is just a description, right? It's not a final diagnosis.
It's a symptom.
It's a symptom. So the guideline defines urticaria as the development of wheals, angioedema, or both. But the precision is in the clinical features. A wheal, the classic hive, has 3 key features.
Okay.
First, a central swelling. Second, what they call reflex erythema, that sort of surrounding redness. And third, and this is the most important part, a transient nature.
It moves around.
It moves around and it disappears,
Yeah.
usually within 24 hours.
And is that 24-hour mark, is that like a hard and fast rule?
It's a very, very strong indicator. If you have a patient and they can point to a specific lesion and say, this one spot has been here for 2 days, the guideline says, stop, pause and think. This might not be spontaneous urticaria.
So if it lasts longer or if it leaves something behind, like bruising.
Exactly. If it leaves behind bruising or hyperpigmentation or any kind of scaling, you have to consider urticarial vasculitis.
Which is a completely different beast.
Totally different. It's a small vessel vasculitis, and it requires a biopsy for diagnosis. So that 24-hour rule is a critical branching point in your thinking.
Okay, and then you have angioedema.
Right, the deeper counterpart.
Yeah.
This involves the dermis or the subcutis, so it's a deeper swelling. And because of that, it's often more painful or even burning rather than itchy.
And it lasts longer.
It resolves much more slowly, yeah, up to 72 hours. But the biggest distinction the guideline makes, and what it really hammers home, is ruling out the mimickers.
The imposters.
Precisely. Just because a patient presents with wheals or swelling doesn't automatically mean they have urticaria. The guideline explicitly, with strong consensus, excludes anaphylaxis.
Which seems obvious, but I guess it needs to be said.
It does. If you have systemic involvement, any respiratory distress, hypotension, GI symptoms, that's anaphylaxis. That is not severe urticaria. The pathophysiology is different. The mast cell activation is systemic. and the urgency is on a whole other level.
And they also carve out the bradykinin-mediated conditions.
Yes, and this is so important for clinicians to remember. Conditions like hereditary angioedema, or HAE. This is crucial because HAE does not respond to antihistamines, it doesn't respond to steroids, and it doesn't respond to epinephrine.
So giving an EpiPen is useless.
It's completely useless. It's driven by bradykinin, not histamine. So the guideline is essentially saying before you even start down this treatment algorithm, you have to be sure you're actually treating urticaria.
Okay, so assuming we've done our homework, we've ruled out vasculitis, we've ruled out HAE, we've ruled out the autoinflammatory syndromes like CIPS or Schnitzler's.
Right.
We're left with true mast cell-driven urticaria. The classification system here has been refined, right? It's a 2-axis system now.
It is, and it's designed for pure clinical utility, to be useful in the clinic.
Okay.
Axis 1 is simply duration. Acute is 6 weeks or less. Chronic is anything that persists for longer than 6 weeks.
That 6-week cutoff has always felt a little arbitrary, but it's the standard.
It is arbitrary, but it's the universally accepted line in the sand. It's the point where we stop thinking of this as a self-limiting acute issue and start treating it as a chronic disease with a significant burden.
And then axis 2 is the trigger.
Right, and this applies specifically to the chronic forms. So here we split it into 2 big buckets. First, you have chronic spontaneous urticaria, or CSU.
CSU. This is the common one.
This is the most common form we see in our specialist clinics, by far. There's no definite external eliciting factor.
Yeah.
You're just sitting on the couch, watching TV, and you break out in hives.
Yeah.
It just happens.
And this can be due to known causes, like autoimmunity or completely unknown causes.
Exactly. Spontaneous is the key word.
Versus the second bucket.
Chronic inducible urticaria, or CIndU.
CEDU.
And here, there is a specific reproducible trigger. And the guideline lists quite a few fascinating subtypes.
Yeah, this list is wild. Let's go through some of them. You have symptomatic dermographism,
which used to be called Urticaria factitia. This is where shearing forces on the skin, like a light scratch, cause a linear wheal to form.
the skin writing phenomenon.
Exactly. You can literally write your name on your own back.
Then you have cold urticaria.
Triggered by cold exposure. And the guideline adds this really great clinical pearl here about the wind chill factor.
Oh, this is interesting.
Yeah, a patient might be able to tolerate 4 degrees Celsius on a perfectly calm day. But on a windy day at that same temperature, they'll react violently.
Because the skin is cooling down much more rapidly.
Precisely. And that's a fantastic clinical pearl because it helps explain why some patients give you these histories that sound inconsistent. Sometimes I'm fine in the cold, sometimes I'm not. Well, was it windy?
That makes so much sense. Okay, what else? Delayed pressure urticaria.
This one is tricky. It's so often missed. The swelling here occurs 3 to 8 hours after the pressure is applied.
Hours later.
Hours. So the classic example is the patient who carries heavy grocery bags and then wakes up the next morning with swollen, painful hands.
Or walking on a hard pavement and getting swollen feet that night.
Exactly. And because of that delay, the patient almost never connects the trigger to the symptom. It makes the history taking a bit of a detective game.
It absolutely is.
And then you have the others. Solar, from UV light, heat urticaria, vibratory angioedema.
Which can happen with things like jackhammers, right? Or even just vigorous towel drying after a shower.
That's right. Then there's cholinergic, which is induced by sweat from heat or exercise, and the really rare ones like aquagenic, which is a reaction to contact with water itself.
Now, one thing the guideline really emphasizes, which I think is a critical mindset shift for a lot of clinicians, is that these aren't mutually exclusive silos.
No, not at all. They overlap constantly.
So a patient isn't just a cold urticaria patient.
No. The guideline explicitly states that patients can exhibit both spontaneous and inducible forms at the same time. You can have a baseline of daily spontaneous hives, your CSU, and then you go for a swim in a cold lake and get a massive flare-up of your cold urticaria.
Or you could have cholinergic urticaria and dermographism at the same time.
Exactly. The presence of one does not rule out the other. And this was a huge point of discussion at the Berlin conference because historically we tended to bucket these patients.
Right, you were either one or the other.
But the real-world data shows this massive overlap. And clinically, we need to document both, or all of them, because the patient's total disease burden is the sum of all of the parts.
That makes perfect sense. If you only treat their CSU, but you ignore the fact that they can't walk outside in the winter.
You haven't fixed the patient's quality of life, you've only solved half the problem.
Okay, let's move into the diagnostic workup. This is section 2. And I have to say, reading this, I feel like the 2026 guideline is really trying to save us from shotgun medicine.
It is. It's championing precision over panic. That's a good way to put it.
So let's start with the most common presentation. Acute urticaria. A patient walks into urgent care. They are covered in hives. It started 24 hours ago. They're miserable, they're itchy, but they're stable. What tests does the guideline recommend we run? Zero.
Zero. Unless the history screams a specific immediate allergy like I ate a shrimp and 2 minutes later my lips swelled up.
A clear cause and effect.
A very clear cause and effect. Otherwise, you do not need to run an allergy panel. Acute urticaria is usually viral or post-infectious or just idiopathic. It's self-limiting.
And testing just muddies the water.
It really does. Testing for specific allergies in a generic acute case is a waste of resources. And honestly, it often leads to more confusion because you'll find these random sensitizations on a blood test that aren't actually clinically relevant to what's happening.
So you end up telling people they're allergic to dust mites, which has nothing to do with their acute hives, and now they're worried about that for the rest of their life.
Precisely. So the recommendation is reassure the patient, treat the symptom with a non-sedating antihistamine, and move on.
But for chronic spontaneous urticaria, for CSU, the game changes completely.
It does. For CSU, we need to understand the potential driver of the disease. But even then, the recommended basic panel is remarkably lean.
Okay, what's on it?
The guideline recommends, with strong consensus, a differential blood count and inflammation markers, so a CRP and NDOR and ESR.
That's it. That's the entry fee.
That's the entry fee for everyone with CSU.
But for the specialist listener, I think the really interesting part is what the guideline calls extended diagnostics. Specifically, the recommendation to test for total IgE and IgG anti-TPO.
Yes. And this is where the science has really evolved in the last few years. We aren't just checking for thyroid disease here.
Right. This isn't about their TSH.
No. We are using these markers to phenotype the patient's autoimmunity. The guideline breaks down autoimmune CSU into two main endotypes based on these markers.
Autoimmunity, type I, and type II. Okay, let's get into the weeds here. Walk us through the immunology, because this has real implications for treatment response.
It absolutely does. So let's start with type I autoimmunity, or CSU-ATI. In these patients, the body is making IgE antibodies against autoallergens.
So self-proteins.
Exactly. Self-proteins. Common suspects are TPO thyroid peroxidase, or maybe IL-24, or even DNA. So essentially, the mast cell has IgE on its surface that is programmed to recognize you.
So your own body.
Yes. When it sees your own thyroid peroxidase floating by, it thinks it's a parasite or a peanut, and it degranulates. It's the exact same biological mechanism as a peanut allergy, but the peanut is your own tissue.
That is a terrifying concept, biologically speaking, being allergic to yourself.
It is. But clinically, these patients often behave like atopic, allergic patients. They frequently have very high total IgE levels.
And that's a clue.
That's a huge clue. Because omalizumab, our main biologic, works by mopping up free IgE. So these type I patients tend to be super responders to omalizumab. It often works incredibly well for them.
Okay, so that's type I. Now contrast that with type I.
Type I, or CSCA-ATI, is a totally different beast. Here, the patient isn't making IgE against themselves, they're making Ig antibodies.
Okay.
And the IgG antibodies are shaped to directly attack the mast cell receptor itself, the high-affinity IgE receptor, Fc epsilon Ri, or they attack the IgE that's already sitting on that receptor.
So it's a direct attack on the activation switch.
It's a direct on-switch attack. When this IgG binds, it cross-links the receptors directly. It completely bypasses the need for an allergen or an autoallergen.
Yeah.
It just tells the mast cell to fire.
And this is the phenotype that is generally harder to treat.
In general, yes. The guideline notes that type I patients often have lower total IgE levels because they aren't necessarily allergic people in the traditional sense. They have higher rates of other coexisting autoimmune diseases. And clinically, they often present with more widespread wheals, more angioedema, and they tend to be more refractory to antihistamines.
So this is why the guideline suggests testing for IgG anti-TPO. It's not just about the thyroid, it's a surrogate marker for this type of autoimmunity.
Exactly. If you see a patient with CSU who has a low total IgE but high titers of IgG anti-TPO, you should strongly suspect you're dealing with a type I patient.
So high anti-TPO and low IgE is a red flag for a tougher road ahead.
Precisely. It doesn't mean you can't treat them, but it manages expectations. You might need to be more aggressive with your dosing or move through the treatment algorithm faster. It moves us away from just, let's try the next drug, and towards let's try to choose the drug based on the underlying mechanism.
What about the classic fishing expeditions? The things we used to always check for, H. pylori, parasites, looking for an occult malignancy?
The guideline is very, very clear on this. Do not do it routinely.
Strong recommendation.
Strong consensus recommendation against routine screening. Only test for something like H. pylori or parasites if the patient has clear gastrointestinal symptoms or a travel history that suggests it.
So no more screening every hive patient for stomach bugs?
No. We are not screening for hidden cancers in every patient with hives.
Yeah.
The evidence review for the 2026 guideline was extensive. The conclusion: the yield is incredibly low, and it generates a huge amount of cost and patient anxiety for almost no benefit.
And even if you find, say, asymptomatic H. pylori, treating it rarely cures the CSU.
That's what the data shows. It might help their stomach, sure, but the hives usually stay. The recommendation is treat the infection if it needs treating for its own sake, but don't promise the patient it's going to be the magic billet for their skin.
So the message is focus on the patient, not the screen.
Beautifully put. If they have gastric pain, test for H. pylori. If they have a toothache, send them to a dentist. But don't do a full-body MRI looking for the cause. In most cases of CSU, the cause is the autoimmunity we just discussed, not some hidden bacteria.
Okay, moving to the diagnosis of inducible urticaria for the CIndU types, it's all about provocation testing.
Yes, but the nuance in the new guideline is crucial. The goal is to determine the threshold.
It's not a binary diagnosis. It's not just yes or no.
Exactly right. It's not just do you have cold urticaria, it's at what temperature do you react. If we use a device like a TempTest or even an ice cube challenge, we want to know, does this patient react at 10 degrees Celsius? Or do they react at 20 degrees?
And that has huge implications for management.
Huge. If a patient reacts at 24 degrees Celsius, their life is severely impacted. They can't go into an air-conditioned grocery store. If we treat them effectively and their threshold drops to 4 degrees, well, technically they still have cold urticaria, but for the purposes of daily life, they are functionally cured.
That's a great distinction. It turns a binary diagnosis into a measurable, objective treatment target. You can show them the progress.
And that's what matters to the patient.
Before we hit the treatment algorithm, we have to mention the PROMs, the patient-reported outcome measures. The guideline lists this whole alphabet soup of them. UAS7, EAS, UCEAT.
And we should learn to love them. They are our best friends in managing this disease.
Why so important?
Because in a disease that fluctuates as wildly as urticaria, a snapshot of the patient in your clinic is totally useless. The patient might be perfectly clear when they see you, but they were miserable and covered in hives yesterday.
The classic parking lot recall bias?
Exactly. The UAS7, the Urticaria Activity Score over 7 days, is the gold standard for tracking CSU. The patient records their number of wheals and their itch severity every day for a week.
And the UCT.
The UCT, the Urticaria Control Test, is fantastic for a quick retrospective assessment of control. It's just 4 simple questions.
What are they?
In the last 4 weeks. 1. How much have you suffered from the physical symptoms? 2. How much has your quality of life been affected? 3. How often was your treatment not enough to control symptoms? And 4. Overall, how would you rate your urticaria control?
And you just sum the points?
You sum the points.
Yeah.
A score of 16 is perfect control. Anything less than 12 is considered poorly controlled. It takes 30 seconds, and it gives you a quantifiable measure of how things are going.
And the guideline now explicitly mentions digital tools for this.
Yes, and this is a big step forward. It mentions apps like CRUS. Let's be honest, compliance with paper diaries is terrible.
Oh, it's awful. They fill it out in the car right before the appointment.
Oh, yeah, I was. A 2 on Tuesday. It's useless. Apps allow for real-time tracking. This ERUSE app, for instance, can send a push notification to the patient's phone. How's your itch right now? It takes 5 seconds. The data is time-stamped. It visualizes the trend for you.
So you can actually show a patient a graph of their own disease activity dropping after starting a new medication.
And that reinforces compliance like nothing else. It's powerful.
Okay, let's get to the main event, Section 3. The 2026 treatment algorithm. This is the roadmap. This is what everyone wants to know.
It is. But before we get into the steps, the overarching philosophy is critical. The goal is complete symptom control.
Not just better.
Not better, not more manageable. The goal is a UAS7 score of 0. Silence. And the strategy is continuous treatment, not on-demand or as-needed treatment.
You're trying to prevent the mast cells from firing in the first place, not just clean up the histamine spill afterwards.
That's the perfect analogy. We want to put a lid on the pot, not just keep mopping the floor.
Okay, step 1. This hasn't changed much from previous guidelines, but the language around it seems to have hardened.
Step 1 is a standard dose of a second-generation H1 antihistamine. Things like bilastine, cetirizine, desloratadine, fexofenadine, and so on.
And what about the first-generation drugs? Diphenhydramine, hydroxyzine.
They are, for all intents and purposes, banned for the chronic use of urticaria. The guideline is incredibly aggressive and clear on this point. There is no place for first-generation antihistamines in the modern treatment of chronic urticaria. None.
Even at night to help them sleep.
Especially not at night.
Okay.
They are sedating, yes, but they interfere with REM sleep architecture. They impact cognitive performance. The hangover effect persists well into the next day.
And that affects school, work, driving.
Absolutely. The guideline cites clear data showing an impact on learning in children and driving performance in adults. Just bad medicine in 2026. We have safer, more effective drugs. We need to use them.
So step 1 is a standard dose of a second gen. If that doesn't achieve complete control after 2 to 4 weeks.
We go to step 2, updosing. We increase the dose of that same second-generation antihistamine up to 4-fold.
4 times the standard licensed dose.
Yes, and this is a strong consensus recommendation. We prefer updosing one modern antihistamine over mixing and matching different ones. The safety profile of these drugs, even at 4 times the dose, is excellent.
Okay, so we've quadrupled the antihistamine dose. The patient is still itchy. Their UCT is still low. Now we hit step 3. And this is where the 2026 guideline really shakes things up.
This is the big change.
It used to be pretty simple. Add omalizumab. Now we have options.
We have the add-ons. Omalizumab is still the anchor of this step. It's the veteran biologic, the anti-IgE antibody. And it works wonders, especially for that autoimmune type I patient we talked about earlier.
Standard dosing is 300 milligrams every 4 weeks.
That's the starting point, yes. But the guideline is clear that you can be flexible. If a patient isn't getting a complete response, you can updose them to 600 milligrams, or you can shorten the interval to every 2 weeks. But now, sitting right there next to omalizumab in the algorithm, we have dupilumab.
The anti-IL-413.
Exactly. Dupilumab has officially entered the urticaria chart. It's particularly noted as a strong option if omalizumab fails, or, and this is a key clinical consideration, if the patient has specific comorbidities.
Like atopic dermatitis or asthma.
That's the sweet spot. If I have a patient in front of me with terrible eczema and uncontrolled hives, dupilumab might jump to the front of my mind as the first choice in step 3.
Because you're targeting that broader type 2 inflammation that drives both conditions.
You're getting 2 birds with 1 stone.
Yeah.
Makes perfect logical sense.
And then we have the new kid on the block, option C in step 3, remibrutinib.
This is, I think, the most exciting addition. Remibrutinib is a BTK inhibitor. That's a Bruton's tyrosine kinase inhibitor.
Okay, for those of us who haven't reviewed our cell signaling pathways recently, remind us why inhibiting BTK matters in a mast cell.
Okay, so think of the mast cell receptor, the Fc epsilon Ri, as a doorbell. When the allergen or the autoantibody rings that doorbell, a wire carries that signal into the house to set off the alarm, which is degranulation.
The release of histamine.
Right. BTK is a crucial, critical part of that intracellular wire. If you inhibit BTK, you effectively cut the wire. The doorbell can ring all at once, but the signal never reaches the alarm. The mast cell stays quiet.
So you're blocking the activation from the inside.
Precisely. And the big difference here is the delivery mechanism. It's an oral medication, a pill, 25 milligrams, twice a day.
That is a game changer.
It's a huge game changer for patient preference, especially for needle-phobic patients or those who have trouble getting to an infusion center.
The guideline does note that availability is a factor here, right?
It does. Market entry is expected around 2025 or 2026, so it's going to vary by country. But clinically, it's a major addition. It provides a non-biologic, small molecule option that, in the trials, seems to rival the biologics in terms of efficacy and speed of onset.
And the guideline puts it on par with omalizumab and dupilumab in step 3. That's a massive vote of confidence for a new drug.
It is. The phase 3 trial data was very strong. The safety profile looked very encouraging, but as with any new small molecule, we'll need to watch for real-world data on things like liver enzymes. But its selective nature is designed to minimize off-target effects.
So step 3 is now a very crowded but very powerful place to be. But what if all of those fail?
We move to step 4, cyclosporine A,
The heavy hitter.
the immunosuppressant. It absolutely works. There's no question about its efficacy. But it comes with a much higher side effect profile.
You have to monitor blood pressure, renal function.
constantly. You're watching their creatinine, you're watching their blood pressure. It is not a prescribe and forget drug like the biologics tend to be. It's really the fallback when our more targeted therapies fail.
I also noticed the guideline mentions benralizumab in a sort of other therapies section.
Yes, the anti-IL-5 receptor antibody. This is an interesting one. We've known for a long time that we see eosinophils in the histology of wheals. We see them in the biopsy.
Right.
But just blocking IL-5 with something like mepolizumab hasn't really been a slam dunk for general CSU. Benralizumab, however, works differently. It binds to the receptor and causes antibody-dependent cell-mediated cytotoxicity. It depletes eosinophils entirely.
So it's more aggressive.
Much more. And the guideline says, consider this if there is comorbid eosinophilic asthma. So again, it's about looking at the whole patient. If your patient has high eosinophils and asthma that isn't controlled, benralizumab might be the key to both problems.
It really seems like the 2026 guideline is pushing us away from a one-size-fits-all approach and towards looking at the whole patient. What else do they have? Thyroid antibodies, eczema, asthma, high EOs, and then choosing the step 3 drug that best fits that specific profile.
That is the absolute definition of the shift from blockbuster medicine to precision medicine.
Mm-hmm.
We aren't fully there yet. We still need better biomarkers, but this guideline is the bridge that's getting us there.
I noticed a few old friends are missing from the main algorithm now. H2 antagonists are gone.
Gone. Famotidine, cimetidine. The evidence just isn't there to support them as a standard recommendation anymore.
And montelukast is out too.
It's been removed from the main algorithm. This is due to the low quality of evidence for its efficacy, combined with the increasing warnings about potential neuropsychiatric side effects.
So what do you do if you're practicing in a setting where a dose of omalizumab costs more than a month's rent, where these new drugs are just not an option?
And the guideline writing group was very sensitive to this. It explicitly acknowledges that drugs like montelukast or methotrexate may still have relevance as affordable alternatives in resource-constrained settings.
So they aren't banned.
Not banned, but they are no longer recommended based on high-quality evidence. The guideline is saying if you have access to the better drugs, you should use them. If you don't, you use what you have. But you should be aware that you're operating outside the primary evidence-based algorithm.
And the final word on steroids?
Systemic steroids are a definite no-go for any kind of long-term treatment. There is a strong consensus recommendation against it. The toxicity is just too high.
But a short course is okay for a bad flare.
Yes, a short course maximum of 10 days for a severe acute exacerbation is acceptable. But you do not, under any circumstances, maintain a patient on long-term prednisone for their hives.
And topical steroids.
Completely useless. By the time the patient manages to apply the cream, the wheel has already moved to a different spot. It makes no sense pathophysiologically.
Okay, let's pivot to some of the nuances in special populations. What about kids? Does this whole algorithm change for a 6-year-old with chronic hives?
Ideally, no. The stance of the guideline is use the same algorithm as adults. The dosing will be weight-adjusted, of course, and you have to check the specific licensing for each drug in your country. But the philosophy is identical.
And I imagine the stance on first-generation antihistamines in kids is even stricter.
Oh, even more so. Do not give sedating antihistamines to children. The data is crystal clear that it impacts school performance and learning.
The old advice of use it to help the kids sleep
is not recommended.
Yeah.
You treat the itch effectively with a modern second-generation drug so they can sleep because they aren't itchy, not because they're chemically sedated.
And what about pregnancy and lactation? This is always a tough area.
It is. The guideline again suggests using the same algorithm, but with caution. It's always a risk-benefit assessment with the patient. But we have to remember, uncontrolled severe urticaria is stressful. It causes sleep deprivation. That's also not good for a pregnancy.
So we don't just tell pregnant women to tough it out for 9 months.
No, absolutely not. That's an outdated and, frankly, cruel approach. We have good safety data for second-generation antihistamines like cetirizine and loratadine. We also have a growing body of safety data for omalizumab in pregnancy, which shows no increased risk of malformations. We can and should treat these patients.
I want to touch on the idea of reevaluation, because CSU isn't always a life sentence, right? It can burn out.
That's a crucial point of management. We should not put a patient on omalizumab or dupilumab and just leave them on it for 10 years without ever checking to see if they still need it. Spontaneous remission happens.
So what's the recommendation?
The guideline recommends reevaluating the need for treatment every 3 to 6 months. Try stepping down the therapy. See if the disease is still active underneath.
So you would taper, not just stop cold turkey?
Always taper. If they're on 4 times daily antihistamines, try going down to twice daily. If they stay clear for a month, go down to once daily. If they stay clear, try stopping. If the hives come back at any point, you just go back up to the last effective dose. You're probing for remission.
Like you're checking to see if the fire is still burning under the lid?
That's a perfect way to think about it. And you do the same thing with biologics. Instead of giving omalizumab every 4 weeks, try extending the interval to every 6 weeks. Then maybe every 8. If they flare, you know they still need it. If they don't, you might be able to stop. It gives patients hope that they won't necessarily be on injections forever.
Let's talk about trigger avoidance for a minute. We mentioned NSAIDs before. Is that a blanket ban for all CSU patients? Never take ibuprofen again?
No, it's a suspected ban. NSAIDs are well-known pseudoallergens. They can worsen underlying CSU in about 30% of patients.
30%, so not everyone.
Not everyone. The guideline recommends advising patients to avoid them if they notice a connection. But many patients tolerate them just fine. It's not a hard contraindication, but it is low-hanging fruit to try. Hey, for the next month, try using acetaminophen instead of ibuprofen for your headaches, and let's see if your hives get better.
And what about diet? This is the eternal question in the allergy clinic. Doctor, is it the gluten? Is it the dairy? Is it nightshades?
The guideline is so refreshing and clear here. It recommends against routine pseudo-allergen-free diets unless there's a very strong, consistent history from the patient.
So no more handing everyone a low histamine diet sheet.
Please, no. Putting patients on these incredibly restrictive diets dramatically reduces their quality of life, and in the vast majority of cases, does not fix their hives. The guideline says, only try a restrictive diet if you really suspect a food trigger, and only for a short, defined period, like 3 or 4 weeks, to see if it actually helps. If it doesn't, stop the diet.
Thank you. I feel like we spend half our clinic time just talking people out of starvation diets they found on TikTok.
It's a major issue. Urticaria is miserable enough without also being unable to eat bread or cheese. Unless it's a proven trigger, let them eat.
So as we wrap up, let's try to summarize the core message of the 2026 guideline. If a clinician remembers only 1 or 2 things from this, what should they be?
I'd say 2 things. For diagnosis,
Yeah.
be lean and targeted. Don't hunt for zebras. Your basic workup is a CBC and a CRP. Use IgE and anti-TPO to phenotype, not to look for thyroid disease.
Okay, lean and targeted diagnosis. And for treatment?
For treatment, be aggressive and be stepwise. Start with second-gen antihistamines, updose them quickly to 4-fold if needed, and do not hesitate to move to step 3 to the biologics or the new BTK inhibitors if you will get complete silence.
And the goal is absolute silence. We are no longer accepting slightly less itchy as a clinical victory.
Correct. The goal is a UCT of 16. The goal is a UAS7 of 0. Complete control.
As we look to the future now, beyond 2026, where is the expert consensus pointing? What are the big research gaps that this guideline identifies?
The biggest gaps are in precision medicine. We're getting better, but we still need good biomarkers to predict upfront which patient is going to respond best to remibrutinib versus dupilumab versus omalizumab. Right now, there's still a bit of trial and error in step 3.
So choosing the right drug for the right person the first time.
Exactly. And the other big gap is in disease modification.
Mm-hmm.
Right now, all of our drugs, even these amazing biologics, are suppressive. We put a lid on the pot, they stop the symptoms.
But do any of them actually cure the disease?
That's the million-dollar question. Do they reset the immune system so that the autoimmunity just goes away? We don't know yet. There's some hope that intervening early and aggressively with a biologic might modify the long-term course of the disease, but we need long-term data to prove it.
That's the window of opportunity theory that we see in other fields, like rheumatology.
Exactly. If you hit the immune system hard and fast right at the beginning of the disease, can you retrain it? Or does it not matter when you start? That's a huge unanswered question. And the microbiome, of course.
Yeah.
The guideline mentions it as an area to watch.
Mm-hmm.
Is dysbiosis in the gut driving some of this immune dysregulation? We don't have the probiotic cure for hives yet, but that's certainly where a lot of the basic science research is heading.
Okay, so here's a final provocative thought for you to leave our listeners with. With the introduction of BTK inhibitors like remibrutinib, we're making a fundamental shift. We're moving from blocking the mediator of the reaction like histamine or IgE to blocking the internal machinery of the mast cell itself. Are we moving toward a future where we don't just suppress the symptom, but we can actually just turn off the mast cell switch entirely?
That is the dream. That is the holy grail. If we can silence the mast cell at the level of its internal signaling, without causing broad immunosuppression, we might be approaching something that looks a lot like a functional cure.
A truly fascinating time to be in this field. Thank you so much for helping us unpack this massive and incredibly important document today.
My pleasure. It was great to talk through it.
To our listeners, the full PDF is out there if you want to get into every fine print detail, but hopefully you now have the roadmap for your clinic on Monday. Keep your knowledge sharp and your wheels gone. We'll see you in the next deep dive.